today, this morning or this afternoon or this evening, wherever you're joining from in the world. We are going to be presenting to you on patient sentiment on perioperative best practice. This is a webinar hosted by RIWI on the Art of Insights series that we've got this year. And I'm really delighted to welcome our guest, Dr. Wael Saasouh, who's joining me today from, actually, I don't know where in the world you are. So please introduce yourself and we will jump right in.
Hi, I'm Wael Saasouh. I'm actually in Michigan right now. I'm an anesthesiologist by training, and I'm a researcher also by background. My practice is in Michigan, and my research is all over. My research focus is innovations and medical innovations and innovations in clinical practice, which is where this project comes in.
Thank you very much. So just as a background, I actually met with Dr. Saasouh probably a year ago now, and we sort of together brainstormed this project. Just for background, I carry out the business development efforts for the healthcare and life sciences practice at RIWI. I've got 10 years of management consulting background. I've advised health insurance companies and pharmaceutical companies, as well as digital and mental health apps and such. I did study international health management at the Imperial College Business School and did biomedical sciences at the University of Sheffield. So we will take you through a couple of slides that we prepared today, and I will share the agenda on screen now. Please feel free to engage with us throughout the presentation, so jump in with your questions. We've also left some time for a Q&A session at the end of the session, but we're happy to take questions throughout. So just for context, I will share with you what is RIWI, what do we do, and what is RDIT. RDIT stands for Random Domain Intercept Technology, and it's one of the key technologies that RIWI uses to collect data. And basically, the core principle behind how it works is that everyone online has a chance of randomly coming across a RIWI survey or message test. And basically, this means that we get as diverse an audience as possible. So the 4 steps here show how a random web user can land on an inactive or lapsed domain. And they can choose without any incentives. So there's no incentives offered, no payment offered. But the participant can choose to opt into a survey if it's an area of interest, and they can then decide to participate. So that's step 2. There are some screening questions to begin with, although we do not collect any personally identifiable information, but we do collect things like demographic data. So the user then anonymously and safely can choose to respond. They can exit the survey at any time as well. And this data is collected and delivered and shown in a dashboard in real time. So there's a few really great things about RIWI, which is what actually drew me to joining the team. Basically, the survey cannot be blocked by any state surveillance or internet control. So this means that we can really capture true patient or population sentiment. It's been used across a lot of different sort of verticals. Healthcare is one of them. And we can get really true sentiment on topics that are sensitive or hard to discuss. There is also geo-targeting, which helps to basically refine by country, region, state, or city, specifically if people are trying to get sentiment on a particular theme in a particular region. That's very much possible. Survey languages are available in depending on the country. Basically, the user can choose their preferred language. And as I said earlier, because there's no incentives, basically people are joining and participating because the topic holds salience for them or they find it interesting to participate. We also often get respondents who've not participated in panels or other surveys. So in that way, the sort of bias and all of that is really greatly reduced, and we get a lot of sort of diversity and representativeness. Also, we cannot really trace a response to an individual. We cannot retarget people or sort of include them in surveys again. So all of this leads to sort of anonymity, security, privacy, and random representativeness. Any questions here before I move on? Brilliant. So we basically came across this theme. Like I said, when we got in contact, Dr. Saasouh and I, we sort of came up with this idea. It was just a seed of an idea where we wanted to improve the kind of data that is collected from patients and by patients. And initially we looked around, and of course we're aware that there is existing patient survey data of some nature. So for example, the HCA-HPS, which is the Hospital Consumer Assessment of Healthcare Providers and Systems. We know that this runs around 4 times a year, so once every quarter. It does have a pretty lengthy survey, and it does cover quite a broad range of topics, ranging from nurse and doctor communication to themes around medication and discharge information, and also things around quality, cleanliness, and like quietness, and finally hospital rating and the willingness to recommend the hospital. So this is one survey that we know that exists out there. And there is also the PRESCANI, which is, of course, many years old. I think it was around 30 years old, founded in 1985 by 2 PhD doctors who were basically aiming to improve the clinical and business outcomes. And they wanted to improve safety, quality, and experience of patient care. I know that this basically includes questions that ask patients about their experience with their doctor. And they also ask about how patients feel about their doctor and what they think when they see their doctor. So it is quite sort of patient-centric in that regard. And the survey is emailed to a select few patients after their visit to that particular hospital. The survey questions basically aim to gain insight on the experience and care, and patients are randomly selected. So that's what we know existed already. But then we wanted to basically give birth to this survey because it really differs from these existing surveys. So like I said, both HCA, HPS, and the PRESCANI are hospital specific. So they basically reach out to patients who attended a particular hospital. And so the type of data that is collected is very different to that of our RIWI survey, which basically goes out to general population. And as such, the reach, the applications, and the potential impact of our survey, this perioperative pilot study, the baseline study that we're going to talk about some findings from, is much, much greater. And you'll see that in the coming slides. I'm actually going to pass it over to Dr. Saasouh, who's going to take us through some of the questions that we asked.
All right, thank you, Avanti. And as you were saying, the existing surveys are valuable for the hospitals because they target their particular population. So if a hospital is interested in their own quality improvement and their own processes, these are very good surveys where they would go to their targeted population. What we're trying to do here is a step further removed. We're trying to get the sentiment of patients who in general go to hospitals. And just for the first pilot project, we chose the surgical population. For that, we need to ask the survey questions on a wider base of respondents. So the value in what we're trying to do adds to whatever existing data there is by making it more generalizable to the country level, not just for a particular patient population from a particular hospital. The concept itself was born a while ago, like Avanti said. We had to start somewhere. So with it being a pilot study and with the budget restrictions and all that, we started on a small scale. So we put together a questionnaire of a few questions, and we sent them out to all the US-based internet users. And we targeted 1,000 full completes for that first pilot project, just to see how feasible it would be and how easy we can do it and how good of information we can get out of it. So we launched this in March. On March 29, we reached our 1,000 completes within 3 days. So as a first step, this tells you how efficient this process is. And it didn't go out to 1,000 people. It went out to several thousand people. And out of those, as you will see from the questions, we filtered out those who had surgery versus those who were caregivers to people who had surgery versus those who never had surgery. And of course, that last group we filtered out. So out of the several thousand patients we reached, within the 3 days, we got 1,000 full completes of the survey, meaning those people are either surgical patients or caregivers of surgical patients. And we had a few questions at the end for those who never had surgery or never been caregivers, and what their sentiments would be around surgery if they were to have any. And you can see days 1, 2, and 3, that was pretty much everything. And as with any good survey, we needed to get some baseline demographics. So next slide, please. And you will notice that the methodology of this survey is a little bit different from what exists. We are relying on people to have internet access to come across the survey when they're browsing. So sort of expectedly, we saw the younger population respond more. As you can see, most of our respondents were younger. It doesn't mean that the other age groups were not represented, as you can see from the other numbers. And you will see a percent respondent, and you will see a weighted percentage. And that basically just adjusts for the census data and would tell you that should this survey be answered by everybody in the country, it would probably look like the weighted column based on the data from the unweighted column. We had 56% male for 44% female respondents. Not too different. Next, please. So then the questions come in where first is a qualifying question. Did you have a surgical procedure on anything in the past 10 years where you were unconscious? And the point of this was, me being an anesthesiologist and a perioperative physician, I wanted to start looking at things that I have a little more insight into. We had a debate between, should we choose 3 years, 5 years, 10 years? Because it's a pilot study, because we're trying to test feasibility, and because we were trying to be as efficient as possible, we increased that range to 10 years, keeping in mind that the longer the procedure was ago, the more recall bias you would have. So we'll take that with a little bit of critical thinking. But as you can see, 65% of people who got this survey never had surgery. And this here is one of the typical points that we have when we do survey-based research. A survey is only as good as the percentage of respondents who come back to you. And the structure is a little bit different here. So if we say that out of almost 2,400 respondents, 65% said no. If this was a targeted survey, this is already invalid results. But what we're doing is a little bit different. So the ones we're interested in are the 18% of those who had procedures, planned procedures, 5% who had emergency, and 7% who were caregivers. Out of those, technically 100% responded. Although there is some bias, again, where we're doing a selection bias, where only people who are interested in answering these questions are responding. And that's always a limitation of survey-based data, where not everybody who's interested was going to respond, even if they had good answers for the questions that you're asking. But accepting the limitations, as everybody does, we went through with this structure. Next, please. And then we wanted to stratify by kind of procedure, and this will become more apparent why it's valuable a little bit later. We split into 4 major surgical procedures, whether they were on joints, on the belly, on the chest, or on the brain. We figured those would be a reasonable categorization, especially that we're sending these surveys to the general population. We're not sending this to medical professionals. And then race identification for all respondents, and we'll talk about this a little bit later as well. Next, please. Highest education. There has been a lot of debate over the socioeconomic status and the educational level with perioperative outcomes, and we wanted to keep that in there so that we can infer some information with our calculations afterwards. And you can see that we have a good split in the groups, and a third of our population has a master's degree or higher, which, if you think about the way we're reaching out to people through technology, it probably makes a little bit more sense. Next, please.
And I was also thinking about the sort of health equity related applications of this. So I know there's a lot of talk nowadays about, differences between different genders, ethnic differences between how much budget is spent on health research for women and men and different sort of races. And I know that this sort of data can also be used to extrapolate and dive deeper where needed and conduct specific studies.
Okay. Now, this is one of the more interesting questions that is not demographic anymore. So we're asking, who were the most memorable health professionals that you encountered during your procedure? And as you may know, going through a surgical procedure in a hospital, you go through multiple areas, and each area has its own specialized team. You have the nursing teams pre-operatively and post-operatively and in PACU. You have the surgical team, the anesthesia team, and you have the ward team back on the floors. And we're trying to capture who is leaving a good impression or a bad impression on those patients, and how can we tweak this in a way to make it a quality improvement initiative for the healthcare system as a whole, not just for particular hospitals. And you can see that a lot of people remember very different people. So a lot of patients remember different people. And you can't assume that if you're having surgery, then your surgeon is the most memorable person or your anesthesiologist. And coming from anesthesia, I thought that a lot less people would remember the anesthesia team, but I got 14%, which I'm happy with. Now, the tricky part becomes, why do you remember that team? Do you remember them because they did something good and they made you feel good, or because it was a problem? And that's where the next question comes in, where we ask, what kind of impression did those teams have? Which it's not on those slides, but we can talk about it later. So then we took each group of those, and then we asked them, how did that team make you feel about your stay? Was it better? Was it worse? Was it indifferent? Next, please. And some of those results we're not sharing on purpose, just because we're in the process of writing this up as a manuscript and we're sending it as abstracts. So some of the data I'm not at liberty to share, but I can talk about the process itself and the concept behind what we're doing. Next, please. And then, how was your recovery from the procedure compared to what you expected? This one is a very important question in my books, because if you ask, was the surgery successful? What kind of answers are you going to get? It really depends on who you ask. If you ask the surgeon, they will tell you that it was successful because they actually went in and did what they were supposed to do. So the pathology was corrected, a tumor was removed, a joint was replaced. Whatever the surgical intent was, as long as we achieved that, then the surgery, yes, was successful. If you ask the anesthesiologist, they will tell you the patient went to sleep okay, woke up okay, was in a very reasonable amount of pain afterwards, and they were discharged with no complications from anesthesia. If you ask the recovery nurses what kind of success would they judge on for surgical patients, they will tell you they came in, they were reasonably awake, they stayed the minimum amount of time in post-operative care ward, and then they were discharged to their rooms or to their houses. So the definition of success really matters. And the whole point of doing this was to do this from the perspective of the patient. So we asked a general question of, was your recovery as good as you expected it to be? Or was it worse, or was it better? And you see a split. So I see 25% of our respondents saying that it was worse than they expected, even though some of those, or maybe all of them, had successful surgeries, if you define it as a surgical procedure, or that they went without any anesthetic complications, or that they had good interactions with nursing teams. They perceived that their recovery from the procedure was not what they expected. And here we look at how we're educating our patients. What is more important to them that we don't see from their point of view? You always get those reports of physicians or healthcare professionals who have had to be admitted to a hospital and that they see things differently from the point of view of a patient. And that's where this question comes in. Next, please. And after a series of those questions, we wanted to ask more. We wanted to know, while trying to keep the survey manageable, and it can be completed within 5 to 10 minutes, we ask where the procedure took place and where the patients were discharged after the procedure. And the important thing here is, if somebody came in from home for a procedure and they went back home, then everything's great. If they came from home and they end up going to a nursing facility, for example, due to a complication, then we want to look into, was this anticipated or not? And we have limited data on this, and we can't probe all the real reasons for why, but at least we can get an estimate of what's happening on a national scale. And we can always argue that the sample might dilute the data so much because it's on a national scale. But the counter argument is we don't have this data anywhere, so that's where we're starting. And in the future, we're planning to do this for a longer amount of time, for a higher number of completes, and expand it to more than one country as much as we can. And we'll talk about the future directions in a bit. And then,
sorry, just jumping in.
Yeah.
This is really fascinating. This is where I truly see how this really sets it apart from that hospital-specific data, you know. These kinds of questions on a national scale are just not asked, are they? So I can see why you're so sort of excited that we're collecting this and that this is the beginnings of something really, really special.
Absolutely. And then we asked about the information that patients received from the medical staff. Did they help them prepare for the procedure or for the recovery from the procedure? We asked them how long it took them to return to the level of functioning they had prior to the procedure. Again, we can replace somebody's knee, but if they're not able to walk on it afterwards, no matter how successful the surgery was, it's not an appropriate recovery. And it could be due to an infection, due to a problem. It could be due to an anesthetic complication. Somebody had to go to the intensive care unit afterwards that wasn't planned. And we're trying to start capturing that kind of information with the survey, and the results that we're getting from this will give us a lot of insight for how to conduct future surveys. Next, please. How long did you have significant pain after the procedure? How long did you take pain medicine, and how long did you have significant nausea or vomiting after the procedure? This is from my perioperative background, where we always say pain is not just the pain score. You can be in no pain, but be so nauseated from the side effects of the medications that you can't properly function. And if you ask patients, would you rather be in a moderate amount of pain or be severely nauseated from side effects, a lot of patients will actually choose the pain over the nausea because it's so uncomfortable. So we wanted to ask all these three. Who were the most memorable health professionals we talked about, and what was the impression that this team left on you? And then for the anesthesia part, because we don't have a lot of work on this, we wanted to see if people recognized their anesthesia team and knew that they seem to be well prepared. A lot of people will just forget about the anesthesia, which in some anesthesiologists' minds is the ultimate success, where nobody even realizes you were there and you did a great job and there were no complications. And then other insights for the patients who did not have surgery. So just so we're not missing an opportunity to collect valuable data, anybody who said no to surgery, we asked them a shorter series of questions where, if you were to have surgery, or if someone you cared for were to have surgery, how important would it be to know and like your anesthesia team, for example? And this was a sample question just to see how the responses were. We directed those more towards anesthesia just because of my personal curiosity. Other than safely going to sleep and waking up, what's the most important thing that you would want to request from your anesthesia provider if you had to undergo a surgical procedure? And I ask this question because pretty much all patients don't get to choose their anesthesia team. You get to choose your surgeon and your surgical team by proxy. You don't get to choose your anesthesia team, especially in the majority of healthcare models. The question is, if you had the chance, would you want to know your anesthesia team? Would you want to choose them? Would you want to ask them specific questions before you come in? Otherwise, you're coming in and there's a lot of things that happen around anesthesia that might be shocking to you or something new, or you don't know that you're not supposed to be chewing gum, for example, or have a sip of water or have a soda before you come to work and come to the procedure. And we get those in clinical daily practice. And a lot of procedures get canceled over things that are easily fixable. what do you think is the best way to be well prepared for a surgical procedure? And this one is tricky because you can't suggest everything. And the structure of this survey research is easiest if you just give them ready-made answers rather than having them as open text and people will just answer whatever they want, which we could do, but it will take longer to analyze. And then which of the below is something you would do to make you feel more prepared for a surgical procedure? And the answers here were, do you need more printed information? Do you need videos? Do you need to meet with your surgical team? Do you want some sort of other forms of education? And we're just trying to see how people would prefer to learn.
This is really, really, really amazing. So, I mean, can you share what kind of organizations do you believe would benefit from accessing this type of data? What is the reach? What is the application? What do you think could happen?
I think we're just starting to scratch the surface on this. As a researcher, this is valuable to me because it gives me insight into a topic that's less well studied, which is patient-centered outcomes. It's gaining a lot more traction lately, and it's a great thing. But I'm going to the patient themselves to ask them directly what they think about this or that. So for researchers, for academicians, on one side, this is good. For anybody who's involved in quality improvement in a hospital setting or in a healthcare setting, this is also important. So these are the smaller teams that we can talk about. Then you can talk about hospitals in general, where they can see where they compare to national benchmarks. Because once this becomes a more established project, we are likely to establish national benchmarks for countries. And then utilizing these answers and the answers of their internal surveys, like the HCAHPS and the Press Ganey, hospitals can start to see where they sit on that spectrum. If you go a level higher, you look at administrative offices of hospitals and healthcare institutions, they can also gain a lot of valuable information from where do we stand as a country on how we're treating our patients and how our patients are perceiving us. And that would drive more quality initiatives in the future. And then you have a lot of pharmaceutical companies and device manufacturing companies, anybody who's interested in the patient perspective or the patient-centered approach or patient-reported quality of care. And I know there are many of those. This would also be valuable to them. And I see there's a question in the chat. Were the benefits to the survey method that surprised you or you didn't expect? Or were there benefits? Are there transferable learnings for conducting studies into other areas of healthcare? Yes. So one major benefit that was surprising to me personally was how quickly we got the responses. And because I'm used to how we traditionally do survey research, and it takes a long time and it takes a lot of effort. If I'm doing in-person surveys even for hospital patients who are within a very limited geographical area, I have to have a lot of hands helping. I have to have people go ask questions. And is it convenient to ask questions now? Are they in pain? Did they just recover from surgery? Are they too anxious about the surgery to even answer your questions? This way, this was a much smoother and easier process where we set up the questions beforehand, sent them out, and just waited for the responses to come back. And everybody who responded was at a good place to respond, assumingly. Transferable learnings into other areas of healthcare, absolutely. We're starting to see the power of this kind of work and what we can do with it moving forward. And I tried to have examples towards surgery and then other examples towards anesthesia, but then other examples that are just general quality measures. And you can see the robustness of what kind of responses we get, especially if we compare those against census data. And we can start inferring a national representation of how, for example, American patients are feeling about surgery and their recovery. And we can do the same thing and replicate it in other countries. And we can start having national and international benchmarks to compare against. So yes, there's a lot in the works. We're planning a lot of projects, and we're happy to collaborate with anyone who's interested. We can share some contact info afterwards.
Yeah, that's actually what I was going to ask. So, are there opportunities for other stakeholders to get involved? What sort of future direction are you seeing for this project? And yeah,
Absolutely.
absolutely share contact details.
There are definitely opportunities. And while we work on putting the structure together of how we can best utilize this in a way that's most beneficial to the people who will be involved in it, we're starting to put together some ideas of who would want to be interested in this data and how would they want to be involved. The fact that this is a very dynamic process where we're simply sending out questions online, and you can see that, say a particular stakeholder is interested in a particular set of questions, we can always add those questions to the survey and then send it out and then get thousands of responses in a matter of days. Any institution that cares for patient-centered outcomes, or anything that you can ask the general population that would affect their mode of business or the way they conduct their healthcare initiatives, would be interested in something like this. And the collaboration that we will have with other institutions and other individuals will depend on where they come from. If they were researchers, we can always think about the next version of the survey and how we can better capture this data. If they were healthcare institutions or quality improvement institutions or hospitals, then we can start looking at how we can compare their data versus national or international, and how we can redirect some of those questions to capture outcomes of interest to them. And then
Yes.
we always talk about, the whole point is for this to happen through the eyes of the patient, so that we can better understand what's more important to them and how we can become better equipped to care for those patients, because nobody goes to the hospital because they like it. And it should be baseline that we as healthcare professionals try to do what we can to make it a smoother process.
Yeah, certainly. Thank you. That's absolutely true. And it really sort of puts it all in context. I'm going to open the floor to any further questions, although this has been really, really illuminating. And thank you so much for speaking on this really important topic.
Yes, and please, if anyone's interested, the QR code is on. If you'd like to collaborate, you'll have our contact information there. You have Avanti's email also on the slide.
Thank you.
While we're waiting, one thing that is a powerful way of analyzing this data is how we can combine questions to come up with altogether new answers. So for example, one of the abstracts that we're writing right now is how well people recover after surgery based on what kind of surgery they had. So then we can isolate, if you remember that question about what kind of surgery you had, whether it was joint or belly or head or chest, split that into 4 different groups. And then for each of those groups, we see how people perceive their recovery. Was it better or worse than expected? And then for each of those groups, we can look at how long did they take pain medications for, how long were they nauseated, how long it took them to get back to baseline level of functioning or to improve level of functioning after surgery. And you can start seeing that there could be a way to distinguish systems-wide processes based on what kind of surgery people are having. So if we say that, for example, all chest surgery patients were having much worse pain scores after surgery than all joint replacement surgeries patients, then we can start looking at, well, maybe our pain interventions for chest surgery are lagging behind. Then maybe we should start to institute more regional anesthetics for chest patients, or maybe we should approach the analgesic treatment plan a little bit differently for them. Maybe what we're doing is working or it's not working. We can start taking from the categories that are working and adapt some of those strategies into the categories that are not working as well as we'd like them to. And that all comes as post hoc analyses, and which is an option available in the survey after you get your results. And we haven't talked about how we look at that data, but anybody who starts one of those surveys will have access to a dashboard where you can do all of those analyses. I see a question: what aspects do you believe future studies should delve into? And this is a very wide net that we can cast. We are starting with patient-centered perspectives on care. We can also start doing some things from the point of view of other healthcare professionals, or from the point of view of hospitals or administrators. We can look at what seems to be more important to patients, and then we can start to subspecialize surveys into those categories. And how can stakeholders get involved? Anybody who's interested, feel free to scan the QR code. Let us know that you're interested, and we can talk offline. We also will be having an offline version of this webinar available to everybody who's interested. And stay in touch, because this is evolving. And feel free to contact Avanti or myself if you have any specific interests in the concept. We will be expanding this much further than simple survey research. We're going to start building a lot of different things from it, and that's still in the planning phase, but we do have some options available currently.
Super. Thank you very much.
Thank you.
It's wonderful. We will close here then today, and we thank everyone for their participation. And like we said, please do scan the QR code to read more, and we do have some more detailed information on how you can get involved. And otherwise, if anything is unclear, please feel free to email me. I've put my email in this chat, or rather on screen, and I look forward to hearing from you. Thank you.
All right. Thank you, everyone.